would like in the beginning to thank my chairman of department, previous one, Dr. Professor Hamdan Al-Hazmi, who was my partner for the last 20 years. I recently moved to a new place, so I thank the university and for his leadership, for unlimited support during the beginning of my career. I'm now into a new place, trying to make new friends and sometimes please new leaders to get what we need to do. But that's life, I guess. So before the talk, I was really worried that how can I beat Kamal? He's a good speaker, he's a great researcher. I'm not the level of his academic career. But you know what? If we were discussing the X-ray on the left side, I have no problem, I'll be the winner. But if we discuss a case on the right side, definitely the Turkish team will win. Now, he made my job even easier when I was listening to his brilliant talk, and he talked about mini perk and super mini perk and showed the excellent work that he's doing. I said the job is easy. I don't have to convince the audience about how important his shockwave is. Let's keep on. We'll try to make this interesting, but again, we both are trying to send a message of safety and efficacy. Now, before having a debate, what are we really debating? And to tell you, my first project was given to me by Hassan Razvi, who was my program director, is to look at the pediatric shockwave in London, Ontario, which was one of the biggest series in the world. That was when I started my urology training, and that was published then. So we are looking at safety, effectiveness, and the cost before we say who would win. So Kamal talked about the initial introduction of pediatric PCNL when in the mid-80s, Woodside published his experience on 7 kids using adult instruments, and they were all stone-free with no complication. Subsequently, Traxler, when he was with Clayman, he published about the safety of PCNL with adult instruments in pig models, and again, that was published with no scarring. Further study of clinical aspect in 61 patients, Dawaba has published that there was no increase in scarring. A very well-designed study from Central Indian, Wadwa published only on 14 children, but those children had the advantage of preoperative and postoperative imaging with GFR, ultrasound, and nuclear scan. And again, there was no difference in postoperative renal function. Now, what about safety of shockwave? I know Kamal is saying nice words about shockwave, how good they are, but he started his talk with a very important statement that it's not FDA approved. And no matter what you think of the FDA, it's a respectable body that looks after patients. So this is put in mind. Now let's go. Before we introduce something, we have to look at the introduction of level of evidence. Now, Newman has studied shockwave in dog kidneys, and there was a negative effect and fibrosis on the parenchyma. Subsequently, rabbit models, again, subsequent parenchymal fibrosis. What about human? Lifshitz in 1998 looked at adult pediatric kidney, and there was some negative effect. You may say these are the old model with HM3, but again, we are presenting the literature. Issues in shockwave, is it really safe? It's obviously the least invasive. Patients like it. You may say Kamal showed us he can do it with neurolip anesthesia or sedation, but it's like gunshot. General surgeon taught us to look around the target or trajectory. Scarring has been looked at. Le Chevalier and his colleague looked at patient with, again, preoperative at 10 hours and even late DMSA after 30 days in 22 patients. Half of them almost have shockwave and have PCNL. And those with shockwave, 7 had scarring. So this is a significant study. What about the potential effect of diabetes and hypertension? You know, this was a big debate or a big talk after the late Segura published the Mayo Clinic database and cohort study when they saw increased diabetes and hypertension later on in life. Again, the same thing was found by Montgomery group, where 8.1% of patients developed hypertension up to 4 years in follow-up. So I don't know, do we tell our patients these things? I think they should know about these, though they've been debated negatively from other colleagues. Now, let's look at the Cochrane Library Review. In a review by this publisher, there was an endpoint, which is the stone-free rate and the need for ancillary procedure or reprocedure. And those showed the favor of percutaneous surgery in those aspects. We know about the less invasiveness in the pediatric population, but we are focusing about safety and efficacy. So definitely you need more procedure, and you need you have higher stone-free rate. Have we looked at comparison head-to-head? Let's see, Ahmed and colleagues in Egypt did a nice study where they compared, this is an adult study, but they look at hard stone. And these are the range that you would probably argue many PCNL, 10 to 20 millimeter. But the interesting thing, the stone-free rate was 30% in the shockwave and almost complete stone-free in the PCNL. And also when you look at, you talked about the fluoroscopy and radiation, those are also more with the shockwave because you needed multiple treatments. I know you are telling me now the stones are very hard here. You are picking very hard to show that it's negative. But again, a lot of urologists will not know these different important factors like you and I would choose, when to do them, because as I will come again in some studies that were done, stones were over-treated by some people more than what the guideline allows you. In this study about efficacy, even with many percusing laser energy, and it shows you the stone-free rate to be very good. Regarding efficacy, again, multiple studies have looked at the stone-free rate. This is a nice review from the group of Rasby in London, Ontario, where they collected database of more than 2,000 people over 20 years, a big database, and they looked at 39 pediatric patients with 1:4 ratio. They looked at annual pediatric and matched them to equal demographics and sizes of stones with adults, and they had a primary and secondary outlook. And the primary and secondary, they were not different from the adult population, except that there were more second-looking kids. Again, this is the study I was showing you. This is the guideline. This is a late study in children by the European Urology Group, expert group, who sat and decided who should get what. So as you can see, the first one, currently my hands are not stable. So the staghorn, the first option is PCNL. The list of the highlighted yellow is something that's not even debatable. More than 20 millimeter. Lower pole more than 10. You may find in the literature some people going beyond the recommendation, but these are respected groups. They were including Kamal, who came with these guidelines of the expert group. Again, one of the drawbacks, they say, you're going to do a PCNL, you're going to put a nephrostomy. We know all the advantage of and function of nephrostomy tube, and we know that what it causes from pain and leakage and infection. These are the indication when we do a PCNL, when to leave a nephrostomy tube. But again, the literature and evidence came with the tubeless PCNL. And this meta-analysis study that was published in the British Journal showed that tubeless PCNL is a good and safe option. And subsequent pediatric tubeless PCNL have been showed by Samad and his colleagues. The recent EAU guidelines I mentioned yesterday, it's grade A evidence level 1B. This is a patient I did with, as you can see in my right hand, I used the peel-away sheet from interventional radiology. We did not have a mini perk like the one you had. In Turkey has a lot of money, so at the moment we did not buy it, but the patient was stent-free and stone-free. So something we did not mention is the cost. Now, I know if you read the literature, the cumulative or eventual effect of cost is probably cheaper with shockwave, but the initial acquisition of the device in a growing hospital or a static hospital is very high. You can see these numbers despite now Dorney has stopped their top of the state device. It's pulled out of the market. I think the highest is Sigma, but its price is about 1 million US, about 3.8 Saudi Riyal million. And not only that, there is high logistic cost of getting the space, training the nurses. The only advantage of that, it's the eventual cost if you have it, as was shown by Mitlaga and his group, where they looked from an NIH grant, look at the economics and outcome for treatment of kidney and renal stone, and they found that ureteroscopy followed by shockwave, then PCNL was the most expensive. I would like to, if you allow me, to share our experience that I started in King Saud University and with my two other hospitals. So we had an 84 procedure in the last 20 years, 15 years. Their age ranged from 10 months to 17 years with, that's the stone size, about 36. Majority of stone were staghorn, and we used all available dilating devices ranging on the duration and the time. Initially, I was doing them all with the adult instrument using the 18 French self-dilator. If I can start this video. Can you help me here? So these are the steps of the procedure. We usually put ureteric catheter, and subsequently, this is a child with Sanjid-Sakati syndrome. We just published that, who had a staghorn. And after putting the ureteric catheter, we choose our calyx. I don't go in until I get a catheter, a guide wire in the bladder. Then I change it with an extra stiff wire to avoid the point one of my Kuwaiti colleagues mentioned of the kidney moving forward. And Dr. Razvi mentioned that he liked to have an extra stiff wire just to hold the kidney in place. After we get the wire down, given that we are in residency program, we try to use a coaxial set with a second guide wire. Subsequent here, I use a peel away 11 French sheath, and I used a ureteroscope, a 6.9 ureteroscope, and laser the fragments and pull it out. At the end, we use flexible nephroscopy using a disposable ureteroscope and make sure the kidney and the ureter are clean. At the end, we do nephrostogram if the patient needs a stent or completely tubeless. This is another child that we choose to do an upper puncture. Can you help me to start this? So when we think upper pole puncture as superior, as most endourologists who work in the prone position, it gives you the nice trajectory to navigate the whole kidney and explore all the calyces with a flexible instrument. And as you can see here, once we get the guide wire in the upper pole, it looks like I can go subcostal or slightly above the 12th rib. Here I was I could manage going subcostal in the upper calyx. And as you can see, I can go all the way down with the ureter and at the end leaving a stent. So once you go in, you have different lithotripsy modality that you can choose from. I'm not going to go in details. Our complication rate were highest initially when we started our studies, but these our numbers. Total of 8 patients had complication. The liver injury patient, when we called the liver surgeon, the nephrostomy tube was there. We just pulled it out like a drain and nothing happened. So this is our analysis. As I said, we are a referral center, so you see a lot of cystine still in Saudi Arabia with related marriages. We get a lot of cystine stones. People who practice there would know that. Unfortunately, these are unfortunate patients who will be your regular customers. When we do metabolic assessment, like we do with all kids, this is what we found. Majority of them are cysteinuric just by bias. A lot of them have normal 24-hour urine collection, but again, about 80% of them don't show up in time. So in conclusion, what is best, BCNL is best for? So, and I think my colleague will agree to send the message that complex or a staghorn stone, if you have a hard stone, if you have a patient with recurrent stone, we know even proponent of shockwave, don't do a lot of shockwaves. We know those will cause eventual scarring. Cystine, especially if they're homogeneous cystine, they don't break up. That's the way the molecule is made. Don't shock them. As you would see in the guideline, lower pole more than a centimeter. If you have a distal obstruction, you can have the ability to have a flexible scope going from the kidney and removing. We are able all the time to do a flexible ureteroscopy and reach the bladder. And I always show the resident, ask them the question, what is this, showing in the balloon with the Foley catheter? And most of the time, a junior resident wouldn't know what that is, but it's easy, non-traumatic. Again, when you have failed shock waves, I don't know, Kamal showed me that studies showing second look and third look. In my country, the insurance will give you codes even for third look or repeated look. So is that safe or not? And we know from the literature, a Turkish study have shown the scarring rate after multiple shock waves. When you have multiple calculi, what do you shock? You definitely will go for a mini PERT. At the end, I thank you, and I wish everybody the best, and for our national team the best.